morning, everyone, and welcome to our event. My name is Sarah Kott, Senior Vice President of Programming at The Hill, and I am delighted to welcome you all here to Medicare Drug Price Negotiation, How to Ensure Access and Equity. I would like to thank our sponsors, Alliance for Aging Research, for their support of today's event. We are here this morning for a deep dive on the impact of the Inflation Reduction Act and on the Medicare program. So far, it has capped the cost of insulin, eliminated out-of-pocket costs for recommended vaccines, and improved access to affordable prescription drugs, and got the ball rolling on direct price negotiations. When you RSVP'd to this event today, we asked you a few questions on what you would like to see when it comes to Medicare health coverage. 24% of you said lower costs, 22% said expanded coverage to include dental, vision, and hearing, 21% said expanded prescription coverage, followed by streamlined administration processes, better access to specialists, and increased provider choice. Our guests today will weigh in on all of these topics and more. But first, a few housekeeping rules. Please put your phones on silent, but you're encouraged to join the conversation. Thank you. Online, we'll be tweeting at The Hill events, and we'll be using the hashtag #TheHillHealth. Now it is my pleasure to introduce our sponsor segment. Please welcome to the stage Executive Director of the Alliance for Aging Research, Susan Peshin, in conversation with Dr. Sarah C. Collins, co-chair of the Health and Policy Committee for the Association of Black Cardiologists. Welcome.
Okay, well, good morning, everybody, and thank you so much for joining us. My name is Sue Peshin, and I serve as President and CEO of the Alliance for Aging Research here in Washington, D.C. And at the Alliance, our team's mission is about changing the narrative to achieve healthy aging and equitable access to care. And for more than 35 years, we've strived for a culture that embraces healthy aging as a greater good and values science and investments to advance dignity, independence, and equity, which is why we're gathered here to discuss this important topic today. We're thrilled to sponsor today's exceptional program from The Hill, Medicare Drug Price Negotiation, How to Ensure Access and Equity. The Hill's editor-in-chief, Bob Cusack, will lead today's discussions with Congresswoman Barragan and Congressman Dr. Larry Bucshon. These informative one-on-ones will be followed by a powerhouse panel featuring leaders we admire from two partner organizations, a prominent business school professor, and a former Democratic member of Congress who voiced concerns about the impact of price negotiation during consideration of the Inflation Reduction Act, known as the IRA. As with any large piece of legislation, there are a lot of moving parts, and the IRA is no exception. The IRA has a number of life-changing reforms that will directly improve Medicare beneficiaries' ability to afford their prescription medications, including a much-needed $2,000 cap on annual out-of-pocket costs in Part D, a smoothing option that gives folks the option to evenly divide their out-of-pocket costs over the course of the year, a $35 monthly cap on insulin, full coverage for all CDC-recommended adult vaccines, including boosters, with no out-of-pocket costs, even if you're in the deductible phase of the benefit. So go get your flu shots and your COVID shots. And a significant expansion of Medicare's Extra Help program for low-income beneficiaries. And at the same time, there are many unknowns, as the Medicare program attempts for the first time to directly negotiate the prices for selected prescription drugs. Price negotiation alone is expected to save the federal government $98.5 billion over a decade, but whether beneficiaries are going to see any of those savings remains to be seen. The Centers for Medicare and Medicaid Services, known as CMS, recently announced the first 10 drugs that will be at the center of these landmark negotiations, and recently held a series of listening sessions on them for patients, family caregivers, beneficiaries, consumer and patient organizations, and others to share input. And we were able to participate in 2 of them, and we're grateful that CMS held those sessions. A lot of what came up in the session centered on concerns regarding access and equity, which is why we're here today. And I'm excited to be joined by Dr. Susan Collins to help ground today's conversation with observations from her real-world experience. Dr. Collins is an interventional cardiologist in Bowie, Maryland, and serves as the co-chair of the Health and Policy Committee of the Association of Black Cardiologists. Welcome, Dr. Collins.
Good morning, Sue. It's great to be here with you today.
Thank you. So let's jump right into it. In September, CMS announced the first 10 Part D drugs that are going to be subject to price negotiations in 2026. 7 of the 10 drugs treat cardiovascular disease or diabetes. What reflections can you share on the drugs initially selected, given their concentration on these conditions?
Exactly. I think it's important to go back to the conversations that occurred in Congress and compare them to how CMS ultimately acts. When the IRA was being discussed in Congress, there was a lot of conversation to build support for the price negotiation that was centered on drugs that really had sticker shock for patients. But ultimately, I don't think that intent was reflected in the first list released by CMS, unfortunately. And as you mentioned, 7 of those 10 medications treat cardiometabolic conditions, which is right up my alley. These medications help patients at a very high risk of stroke, heart attack, pulmonary embolism, deep vein thrombosis. Others are used to treat diabetes, chronic kidney disease, and heart failure. The prices for these drugs aren't trivial, but they're already heavily discounted. When I look at CMS's list, what makes it notable is that millions of Medicare beneficiaries rely on these drugs. Most were chosen based on volume and total cost to Medicare, and I get it, but what that means is the potential for harm if access is restricted is substantial. It's also important to put a spotlight on how these conditions disproportionately impact communities of color. We all know that Black adults have the highest rates of stroke, heart failure, hypertensive renal disease, as well as the highest premature cardiovascular mortality in the country. Hispanic, Black, and Native Americans are 40 to 50% more likely to be diagnosed with diabetes than whites. So when you consider these factors, any layering of utilization management that Part D plans to use on top of negotiation is going to hit Black and brown people harder.
Absolutely, yes. And what we're worried about is how CMS currently, but we have hope, has only pledged to monitor utilization management by Part D plans because we really think it's too passive. With the IRA's Part D plan restructuring changes, insurers are going to be responsible for 60% of costs in 2025, which is up from 15% today. So that's quite a jump for them. And we think it's more likely that payers are going to look to manage beneficiary costs more actively through the use of prior authorization and step therapy. Also, the IRA guarantees formulary inclusion for all 10 of the selected drugs, but it doesn't guarantee formulary placement for any of them. So if a plan switches formulary tier placement for a selected drug, beneficiaries might need to either pay more out of pocket to stay on it, switch to a preferred drug in the same class, or switch to a new plan. And so what I would love to know from your experience as a cardiologist, do these kinds of scenarios concern you?
Absolutely. I'm going to get into the nitty-gritty sort of, back of the house type of stuff, because I think that's where I can be the most impactful today. So we prescribe medications based on their direct knowledge of the patient's medical history, their life circumstances, and what's most likely to result in the best outcome for them. So Eliquis, Xarelto, and Entresto are a few of the medications that are on this price-setting list. These are also among the drugs that we prescribe the most frequently in our practice, and the ones we have to institute prior authorizations for, unfortunately. So what's concerning is that Eliquis and Xarelto are blood thinners that help to prevent stroke in patients with atrial fibrillation, in addition to other clot prevention measures. They are the medications we use first line because they are the best drugs by a landslide. They have the best safety profiles, the best outcomes, and nothing else comes close. They're life-saving medications, to be clear, and the alternatives are just not anywhere as effective. Along the same lines, Entresto is our first-line drug for heart failure. So utilization management complicates our ability to prescribe these medications and puts our patients in a precarious position as a result. The prior authorization process is not straightforward either. So you would think that when we prescribe the medication, you go to the pharmacy, you pick it up, it's a done deal. But when utilization management techniques like prior auth, which I'm going to harp on today, are instituted, when the person at the practice assigned this responsibility is usually a very busy medical assistant who's typically being paid minimum wage, by the way, or a biller at larger practices. And that takes the responsibility of prescribing the medication out of our hands and places it on our support staff. So in the meantime, you're at the pharmacy and they tell you, we're waiting on the doctor's office. What's actually happening is back at the office, this medical assistant is engaging in 3 to 4 back and forths with utilization management companies. Some of those happen over the phone, some of them happen through your electronic health record, some of them happen online, but they are juggling these prior authorizations for every single patient who requires it in the middle of doing everything else. We have a small team, and we have one person whose job it is to do all of these in addition to patient care. Wow. So you can imagine the load on that person, but the gravity of what they're being tasked with. Yeah. They are basically petitioning the payer to get the drugs that we are prescribing in the patient's hands. And you can imagine that's also worse in some offices that are seeing predominantly underserved patients. They tend to be understaffed. And in many cases, despite their best efforts, this prior authorization doesn't go through, it's denied. And we often don't find that out until the patient returns for follow-up. Oh, wow. So if you can imagine you prescribe a medication and you see the patient 2 months later, and you don't know that that medication has not been approved, typically those notices come, the patient may get a letter in the mail. I don't even open my mail, or through a fax. We all know where faxes end up. So we often don't know. So it's already difficult to institute a plan of care in populations that are challenged by socioeconomic status. Every layer of utilization management adds a barrier to care in our most fragile patients. And like I can't emphasize enough that this is life-saving care. These are not novel drugs. And older adults have spent their whole lives paying into Medicare, so they deserve the same medications as everyone else. So my sincere hope is that CMS institutes guardrails to prevent utilization management from rationing healthcare, rationing the healthcare that's so devastating to our patients who are in the most need.
Yeah, well, I appreciate that. How, is this like a daily struggle that you deal? Mm-hmm. Yeah, interesting.
Yeah, my medical assistant, whose day ends at 5, called me at 6 about a prior auth last night because she was still running through them to get her day finished.
And then I know that when we spoke, you said that you all try to do your follow-ups sooner because you know that
for this exact reason. Because when I prescribe a medication, I have no idea if it's going to get in the patient's hands for coverage reasons, prior auth reasons, a whole host of reasons. So I see them back almost immediately afterwards just to make sure that that loop is closed.
Is that the usual practice at
No.
most? How long do most people?
We have structured our practice so that we have room in our schedule to take time with our patients, but that is exceedingly rare, and it's a gift, and we have an advantage in that regard. Most practices are insanely busy, and I've been in practices where I was booked up 6 months in advance, so I didn't have the leisure of seeing my patients back quickly. I just had to sort of try to train them to say, look, if you can't get the medication, please call me immediately or send me a message.
Yeah. I know from my own experience taking care of my mom, older adults recognize the medications they take. So if something switches color or shape, they see that and they're like, I don't know if I want to take that. That doesn't look familiar to me. So it's important that CMS recognize those issues. So it's clear to us anyway that CMS has a lot of work to do to prevent Part D and Medicare Advantage Part D plans from setting up barriers to access and equity on the selected drugs to the point of abuse. We just really want to make sure that it's not overdone, and I think there is a high risk of that. So Dr. Collins, thank you so much for sharing your valuable insights and for being with us today. And I'm going to turn the program back over to Sarah and to Bob Cusack. Thanks so much for having us.
Thank you, Susan Peshin and Dr. Sarah Collins. A recent survey by the Commonwealth Fund found that health care is unaffordable for many Americans. 51% of Medicare recipients said they struggle to afford health care, with 42% admitting to skipping or delaying health care. So is direct price negotiations the answer? How do we make healthcare more affordable? Joining us in this discussion are our panelists, former Congressman of Oregon and now principal at William Jensen, Kurt Schrader, Craig Garthwaite, Director of Healthcare at Northwestern Kellogg School of Management, Dr. Gary Puckin, President and CEO of the National Minority Quality Forum, and Melissa Mitchell, Executive Director of the Global Coalition on Aging. Here we go. Oops, I'm so sorry.
Thank you. Thank you, Sarah. I want to go down the line and in a brief way do intros, but also one takeaway you want the audience, both in person and online, to take away on Medicare price negotiations. Congressman, we'll start with you.
Well, it's going to be an exciting 2 years, see how things play out, particularly in the negotiation space, to be sure. But I guess for seniors, I'd like to think the glass is a little more than half full, because out-of-pocket costs will indeed be capped at $2,000, whether or not the negotiations go up, down, or sideways. So for our senior population, hopefully be all right. But as alluded to in the earlier panel, access to some of the medications could be severely restricted depending on how that negotiation process goes. So stay tuned.
Craig?
Yeah, in some way, it was interesting to hear the sort of set of things people wanted out of the talk, which was like 20% want more access, 20% want lower cost, 20% want more specialists, which kind of illustrates the difficulty of doing health policy, which is very hard to solve all of those problems at once. If we are talking about sort of the drug price negotiations and access, in many ways it all just is an access question, but it's an access question over time. And so I share the Congressman's view. The seniors are going to largely be okay when it comes to drug price negotiation, because the pain's going to be 15 or 20 years down the road, right? We're going to get access in the sense of lower prices to drugs today by pushing down the prices on those drugs, which will decrease investment into the sector, and then 15 years from now we'll get fewer products. And so it's really, like who's going to be most immediately hurt? If you're like 40, 45 years old and you're going to live for 30, 40 more years, you're the one who's going to get fewer access to drugs going forward. And so the access problem is going to have to be somewhere. It's a question of where we want to push it off. I think the politics of DC, unfortunately, are such that things that are pain 20, 30 years from now are a very easy thing to pass in some ways, because it's like, well, who cares? Like I'm not going to be in Congress then. I'm not going to be around. I don't have to suffer the penalty, and I can promise all of the goodies to people today. I think that's what we're seeing, certainly from the current administration, but also from the supporters of the IRA.
Gary?
I think IRA sort of sits on top of a really deeper problem that we have in American healthcare. We have a tiered rationing healthcare system. You heard some of the rationing from the doctor early on, and when you're rationing, you're necessarily going to produce inequities because you're picking winners and losers in the system. And IRA has a great opportunity to exacerbate that problem, and that's what we're deeply concerned about. There is nothing in IRA that actually deals with equity. And we have to get equity into our healthcare system, and that means we have to challenge the rationing that's going on. Formularies are rationing, right? They pick winners and losers, and we can't have, particularly in a government program, picking winners and losers in healthcare. And then finally, for me, I'm sorry, I only attended one eco course, and it completely baffled me. But the only thing I really picked out of that eco course is government price controls are not a good thing. I'm sorry. I ask my economist friends that all the time. How is it possible in healthcare that government price controls make sense when every other part of our economy we say it doesn't make sense? So anyway, I leave you with that thought. If you can find an eco major to tell you how government price controls make sense in healthcare, I'd love to meet the person.
Melissa?
Yeah, no, I'd love to pick up on some of those points. And I think we have to think about equity as we're looking at the impacts here. We want to make sure that there is access to these drugs to all of our communities. And then we need to look at the impact on innovation and access overall. We see that in Europe, in some cases, that having similar price controls to these have led to a particular cancer drug reaching the market 240 days later than it did in the US, and that had a huge cost to upwards of 30,000 life years. And so we need to make sure that we are looking at this from a very equitable lens. And then also we have to make sure in the long term, exactly what Craig said, we can't stifle innovation overall. This has ultimate market impacts in terms of how it's going to impact individuals. We need innovation. How did we get here? How do we get to having longer lives and longevity? That's through innovation. That's innovation as simple as sanitation and refrigeration, but also innovation in healthcare and in innovation in new drugs. And so we need to make sure we continue to foster an environment that allows for us to innovate new drugs and make sure that as we have longer lives, we also have healthier lives.
Picking up on those points, the Global Coalition on Aging partnered with our sponsor, Alliance for Aging Research, to provide CMS recommendations on drug pricing. Can you give us kind of a brief rundown of what those recommendations were?
Yeah, so our great partner, Alliance for Aging Research, thanks so much for inviting me here today, Sue. We got together with the Alliance and 38 other patient and advocacy organizations to say what are the impacts of drug price negotiations overall. And we found that part of it is the process. How do you engage individuals? How do you engage beneficiaries? How do you engage advocacy organizations in these conversations? We think it's very important that in the process, we have to be very transparent. What are we trying to get out of these conversations? How are we reporting back to individuals? And how do we make sure that there's representation of those who are going to be most impacted by these conversations, actually contributing to the policy conversation? So that was really critical to us. It's very important that we don't discriminate based on age. We realize there's an inherent ageism across our healthcare system. Oh, you're getting older, or these things are going to happen to you anyway. Your life is going to be shorter in the long run, so we don't take as much consideration. And we have to make sure we remove that, and how we value drugs is very important. And then what I said about innovation is we have to make sure we focus on the long game in terms of where innovation happens. And on the equity point, we have to focus on equity to make sure that where people live doesn't determine if they live, and so therefore the access to these drugs is paramount.
Well, speaking of equity, Gary, in September, the National Minority Quality Forum joined 18 other groups to form the Data Equity Coalition. Can you tell us a little about the coalition, why it was formed?
So one of the problems that we have is that we don't disaggregate healthcare data, right? So if you go to the Congressional Budget Office, you know, it's African Americans, white, Hispanic, Asians, and Asians include Pacific Islanders, East Indians, Chinese, Japanese. I mean, it's an incredibly bad system. And so we partnered with a number of organizations to begin standardizing data collection, because you can't fix what you can't measure. And so we have to be able to distinguish cohorts of patients, and so we built that alliance to do just that. And by the way, I want to give a shout out to Blue Cross and Blue Shield, because they're one of the payers, and I want to say that we talk to a lot of payers. I think the payers are ready to change the system. They want to get paid for outcomes, and we need to give them that opportunity. And I just think that we're not reaching out the way we should with them to say, okay, let's get away from rationing, let's pay for outcomes, and part of standardizing the data is the first step in that direction.
Could that be done administratively, or does that Congress need to step in on that?
So what's happening, Congress gives each of the agencies mandates to collect data, and so they're all collecting different data sets, and so somebody needs to harmonize over there at Congress so that we get one set of data that actually, standards that is, that actually allows us to measure the health of the American population. Our future is really about controlling health outcomes. That's where the science is taking us. We're getting incredibly smart. If you look at what's going on in cancer, it's amazing. Look what's happening in diabetes. We're extending life. HIV is now a chronic disease. Hepatitis C is a cure. And here we're having this conversation about pay for. I'm sorry. I think we're missing the boat here.
Craig, you study the relationship between health insurance expansions and drug prices. What is the impact of prescription drug prices here?
What do you mean exactly?
Just on when you look at the implementation of this law, what most concerned about?
So I think it's going to be a real question about what drugs we pick, and Dr. Collins talked a bit about this as well, as to what are we trying to target and what are we trying to get out of this system. So I think it's going to be an interesting 2 years in the sense, first, of seeing what those first prices are that come out of the, I mean, I guess we'll use the term negotiation. I don't really think you can call this a negotiation. I guess, like, you negotiate with a mugger when they show up. It's like your money or your life. I mean, technically you've got two options there, but I think most of us don't think of it that way. Here, CMS just has an amazing amount of power when it comes to this. It is a accept our price or leave the Medicare system entirely with all of your drugs. Not just with this drug, with all of your drugs. We wouldn't allow private payers to have that kind of conversation. That would be an antitrust violation. We wouldn't allow prescription drug companies to do the opposite and say, you either take my price for all my drugs or I take all my drugs away from you, right? The FTC would clearly make that an antitrust violation, but the CMS, because the government agency, is able to do this. And so seeing how they choose to wield that power, I think, is going to be very informative here. They're instructed in the law to get the lowest price possible. The lowest price possible is zero. Right? I don't think they're going to do that, but that is the lowest price possible. So how much credit are they going to give you for your clinical value over a therapeutic substitute, right? We talk about drugs like Entresto, which are really good for heart failure, but we've got a lot of people who don't fully respond to that, depending upon the type of heart failure they have. We want more treatments to use in combination with that. We know there are companies trying to invest in that. Are they going to get rewarded if they provide more therapeutic value over what's classified as a therapeutic substitute? Those are the kinds of questions we need answers to, and we'll get those over the next 2 years.
Kurt Schrader, you were in Congress when the Inflation Reduction Act passed. It started out Build Back Better, and then it was kind of cut in half. Take us behind the curtain of how this policymaking happened and maybe some of your concerns of how the policymaking happened.
Well, the theory was it was a Build Back Better. I would respectfully suggest that actually there was no written language to a lot of the social programs that some of my colleagues were very interested in including. Some were very good, but again, came at a significant cost and did not have the bipartisan support that some of the other elements had. It was interesting to see how things played out. H.R. 3 was the original vehicle, had been a Democratic priority for several years, couple of Congresses, and it failed each time it came over to the Senate. And to some of us, that looked like doing the same thing again and again, expecting a different result. What the definition of insanity? So some of us tried to come up with a way to make it work. The drug, a lot of pharmaceutical companies I talked to were all on board. We're sharing some of the cost to reduce senior copays. They get no credit for that. The pharmaceutical industry gets no credit for coming in along with the insurers and saying, hey, you know, this is an area we are willing to step up and deal with, help close that donut hole at the end of the day and make it happen. I remember having conversations as a problem solver with Senator Grassley on the inflationary rebates, not a huge popular thing amongst my Republican colleagues and some of the companies, very concerned how that could play out at the end of the day. We'll see. I mean, that's now into effect, so we'll see how that either affects access to some of these drugs or dissuades people from making them in the first place. So, but these things are, frankly, folks were stepping up, willing to deal with that. The bigger issue was the drug price negotiation. That was supposedly the holy grail, and as has been alluded to here, I think it's very questionable as to whether or not we actually have a negotiation process going on. It is totally, I think, in CMS's hands to see if this either works or does not work at the end of the day. They do have somewhat unilateral control. They're being sued, as you well know, by every single pharmaceutical company whose drugs are on the list. I think it would be malpractice if they didn't at least step in and question the constitutionality, the legality, the trust issues that Craig alluded to. But we tried to find a sweet spot, if there is such a thing, between stifling innovation completely, which H.R. 3, in my opinion, did. 30 to 40 drugs would not come on the marketplace every year as a result of the way H.R. 3 was written. That's pretty substantial. I talked to my seniors back home in my district, and they were when that got out, they were very concerned. All of a sudden, drug price negotiation took on a different flavor. And so I tried to, with some of my colleagues, ameliorate some of that. Theoretically, we're at a point, according to CBO, we'll see in the real world, where maybe we'll have one innovative drug not come on the marketplace every 10, 15 years. And that's a trade-off, lower cost versus maybe doing that. And we'll see if it's actually true. To have the panel's whole point, over the next few years, as a member of the United States Congress for more than a few years, you propose things, you legislate, and then you realize, well, this didn't work out quite the way I thought it was going to be. It's not really real world efficacious. And everyone in this room will hopefully push back, give us feedback on what's working, what's not working, how draconian CMS is or is not at the end of the day. I mean, the penalties, I think, are outrageous, both the excise tax and can't sell any drug on the marketplace. That's kind of wrong. I don't think that passes much with Democrats or Republicans at the end of the day. The law self-mandates that the prices have to be, at least depending on how long the drug's been off patent, 75% down to 45%. And that's pretty substantial. CMS could bring it to zero. If they do that, I think the world will be a different place, and CMS will be a very different place at the end of the day, because that would be terrible and catastrophic.
Do you think there's enough congressional oversight on this issue?
I don't think there's a whole lot right now. I'd be curious what my good friend Representative Bouchon and Barragan think at the end of the day. I think we're waiting to see how this plays out. As most everyone in the room knows, and it was pointed out earlier, most of the provisions are only now starting to take effect. The drug price is a couple of years off. The copay stuff will be probably, this next year they'll get a huge benefit, but it'll be, more effective in 2025. So to stay tuned. The more they hear from you at the end of the day, the more Congress will be inclined to do a little oversight. That's the real world.
Well, let's get into cost, because that's a huge issue for the Medicare population is affordability. And really anyone else on the panel, you want to take this as far as what are your concerns about costs? Like we've talked about savings, but who's getting those savings? And as former Congressman mentioned, CBO comes up with these estimations. I remember when Part D was created, CBO overestimated how much it would cost. Cost was a major issue. But I'm talking about the cost for seniors. Anyone want to take that, Gary?
So when you actually look at the data, right, the average household income for a Medicare beneficiary is $25,000 a year. When you look at their out-of-pocket copays, it's about $6,000 a year. Most of that's hospitalizations and emergency room visits. It is not prescription drugs. And so part of the fix is, how do we help them keep them out of the hospital? How do we keep them out of the emergency room? The prescription drug cost average out-of-pocket is somewhere around 20%, 24% of that $6,000 is what Medicare beneficiaries are paying. When you look at IRA, it's not really clear that they're going to benefit much out-of-pocket from it. And so the theory that CMS is operating on is they push down the cost. They're going to lower the out-of-pocket. But when you go in and actually look at the data, about 50% of Medicare beneficiaries are on low-income subsidy, right? So they're already getting the benefit. And if you really wanted to help them, help more Medicare beneficiaries, you'd fix the low-income subsidy and bring more of them in. You'd have to go into this elaborate drug pricing, whatever, in order to get to help Medicare beneficiaries have lower prices. And the point I want to make, because it's incredibly important here, is that we're not looking at the data, right? We're making all of these policy decisions without looking at the data. I'm going to take AFib, because that was on the prior panel. 48% of Medicare beneficiaries who have atrial fibrillation are on no medication, right? None, right? And so their risk for stroke is very, very high. African Americans on atrial fibrillation are getting warfarin, when we know it doesn't work for them, right? We know it doesn't work for them. So, I mean, you got to go in and look at the data and make data-driven decisions. Health policy has to follow the science, right? Congress, health policy has to follow the science. CMS, health policy has to follow the science. None of you get to make policies that are not aligned with the science, because the minute you do that, you are going to create inequities, you are going to have bad outcomes, and that's what's happening right now, because we don't look at the data, we don't follow the science when we do health policy. We think we can just make it up, and we can't. You have to follow the science.
I think I'd be a little more positive about the IRA on cost containment, or out-of-pocket payments, though. Yet, if you want to focus on the average, that's one measure, obviously, in the data. I think if we start looking at the tails of that distribution on out-of-pocket payments, Like we had a system under Medicare Part D prior to the IRA where if you were forced to take an oral chemotherapy and you didn't have a supplemental program or insurance, of which there are a number of people who do, you had effectively unending liability. You were uninsured for your cancer treatments. If you had to take Revlimid, you were taking 12, 13 grand out of pocket for some of those people. That's an unconscionable insurance system that has people pay that kind of money out of pocket for a drug I want to know of which there's no concern of overuse. There is no one who's like, gee, if you cut the price of Revlimid out of pocket by a little bit, I'll take more of this thalidomide derivative, like thalidomide derivative, right? That's just not how these products work. And so the system was not working very well, and the system was set up to take money from sick seniors and give it to healthy seniors in the form of lower premiums. That was what Medicare Part D was doing before the IRA. It was almost reverse insurance. We were punishing the sick and rewarding the healthy. And so I think the system is doing a better job on that. We can work on sort of average out-of-pocket payments and access for that, but we should acknowledge that for people who were hit the hardest by this, and let's note that insurance is meant to help the people with the biggest financial burden. That's not the average person. That's someone taking a drug with a really expensive out-of-pocket payment. The IRA is going to help that. And so while I don't like the drug price negotiation side of the IRA, I think it has meaningful problems on access in the long run, I think we have to give credit that it fixed a known problem, and it was a bipartisan solution to that, because everyone knew this was a problem in the way the law was written. I think the problem we have in terms of like oversight is that we've known that was a problem in Part D since about 2 or 3 years after the law passed, but we couldn't get any will to do anything. And I think for the IRA, my worry is even if we figure out in the next 2 years that there's big problems, I don't see Congress putting itself together and actually passing any sort of solution to this. And that's sort of my worry with these laws.
I'm going to jump in because this goes back to the rationing question that I raised with you earlier, right? So we created the rationing system. When Part D was put in place, we stood up and said, you should not have a formulary in Part D because you're going to pick winners and losers. The president of the company pays the same thing as the janitor. I mean, that's ridiculous, right? And so when you force people, it's a tax program. Medicare is supported by taxes. And so government should not pick winners and losers, and you're doing it when you create those formularies. That's really the problem. So IRA comes in, and it fixes the problem that it created, right? We shouldn't have formularies. I mean,
So if we're not going to have formularies, how are we going to have drug price negotiation at all? Like at some point,
I'm not arguing for drug pricing negotiation.
But at some point, there's got to be a way to control spending, right? And there's going to be some pain from that, and someone's going to have to bear it. Right? If we don't like formularies, if we don't like prior authorization, we don't like drug price negotiation, then we like unending payments to industry, which I think some people in this room might like, but that's not going to work for the taxpayer.
You haven't heard me say that either.
No, but you've effectively said it.
No, well, give me a chance, and I'll iron it out for you, okay? First of all, what we believe in is competition in the marketplace, right? I mean, that's the essence of our system. We're not a command economy. We believe that we should compete in the marketplace, and we have to create transparencies and power, and government should use its power to increase transparency in the marketplace. If it was left to me, and you're asking me how to control drug pricing, the first thing I would do is look at the clinical trial infrastructure. We need a national clinical trial infrastructure because a lot of the costs in drugs are sitting there because they're trying to recruit patients into clinical trials and a whole business.
If you lower the cost of drug development, drug prices will stay exactly where they are. Pharmaceutical companies will keep charging whatever they can. Profits will go up. You'll get more drugs. That's what, I mean, I like more drugs, but like.
I'm talking about competition, right?
But competition between who?
Drug companies, they compete.
How do they compete? They compete by getting on the formula.
No,
let me have Melissa jump in. What are your thoughts on this? Or you want to referee it?
This is a great conversation. I think we need to have it. Maybe we'll continue it afterwards. But I think when you think about the cost to individuals, and you think about cost to beneficiaries, cost to Americans, I think, yes, in the short term, we're seeing benefits of it. But then overall, what are the costs? Because access, to me, is also a cost, right? So if you limit the access overall, and if an aging individual has multiple chronic conditions, have been on a number of these drugs over time, and they're with the monitoring and the picking winners and losers situation, if we have to switch a drug because of the rationing, then that is not going to be good for individuals. So I think when we look at overall, what does this mean for our parents? What does this mean for us? What does it mean for us down the line? As someone who takes one of the drugs who's on the list right now, I worry down the line, 20, 30, 40 years, what is that going to look like? What is the overall cost to be if I don't have access to that medicine? So non-medical switching because of cost and not because of what I talk to my doctor about or because of what a payer does or does not pay for. We cannot have that in the system. And to me, that's the biggest cost that's going to have an impact on Americans.
So I guess I'd point out that while we're talking a lot about the drug price negotiation, that will have a huge impact potentially on innovation going down the road, what pharmaceutical companies do. You know, the drug price problem is not just pharmaceutical companies. Their price increases over the last few years have been actually fairly minimal. What are other parts of the system we need to be looking at? And I know my friends in Congress right now are looking at the pharmacy benefit managers right now. You know, what role do they play with this kind of converse, inappropriate, you know, rebate that they get at the end of the day? But how do you deal with that without increasing premiums inadvertently on Medicare beneficiaries? That's a problem my colleagues have to struggle with. And frankly, Congress is stepping up and doing some oversight and actually working in this arena to make sure that we're not just pushing on one spot of the balloon to have it pop out somewhere else. They're looking at the whole drug price cost system to make sure that there's an opportunity to deal with that. And I respectfully think that my friends in Congress will step up on some of the draconian penalties that are in there. I think there are things that slipped in under the radar. I think that's a Democrat and Republican issue at the end of the day. Probably have better success there than in the court system if you want to change how this plays out. And also the amount of authority that Secretary of HHS ultimately has through CMS to dictate the results.
But on that, we have about 30 seconds left. So you do think Congress could actually work together on something as radioactive as the IRA was and agree on some kind of technical correction bill?
Absolutely. Congress gets underrated. The last Congress I was in, that was the best Congress I've been in 14 years. We did the bipartisan infrastructure bill. Huge bipartisan success that involved the health, welfare, productivity of every American for the next 20 years. That's huge. Get no credit for that, but it's huge, for goodness sakes. IRA, a lot more controversial, but you know, outside of the drug price thing, you know, we actually have some stuff now on energy that hopefully looks at both the fossil fuel and the renewable fuel. We did the CHIPS Act for computers. You know, we did gun control, if you remember right, at the end of the day. So a lot of good things Congress can do, believe it or not, when it gets its mind up. And this is an issue that resonates with everybody, so I think there's an opportunity to do some bipartisan work.
Well, on that note, please thank our expert panel for joining us this morning. Hey.
Thank you.
Thank you. I'll hand it back to Sarah.
Thank you to our panelists for that excellent discussion. Are we set? I'm going to let our folks set our chairs up here for a moment. Okay. I'd like to welcome to the stage Bob Cusack, and he will be in conversation with Congressman Larry Bouchon of Indiana. He is the Vice Chair of the House Energy and Commerce Subcommittee on Health. Welcome, Congressman.
So, first, I want to kind of start with some news on the day. It doesn't look like a supplemental is going to get done before you guys leave. Is that your take, and do you expect that the House to adjourn sometime later this week?
Yeah, I think that's my take. Unfortunately, for me personally, I think, you know, I've been a supporter of our efforts in Ukraine. I think we can't allow Putin to take Ukraine. He'll then go into NATO countries, and then we'll have our own men and women with their boots on the ground. I think that's the majority opinion in the Congress overall, on both across the House and the Senate. But honestly, from our perspective, I do think, you know, the domestic issue related to the southern border and that is something that is, you know, has been a barrier to getting compromise on the funding solution. So I think it's really unfortunate. I saw some comments coming out of the Senate yesterday saying that they're not going to probably address it before the end of the year, and so I think that's unfortunate. We should.
And do you think what would be part of the solution? Mitch McConnell has said the president should get more involved. We've talked to some members who've said the same thing.
Yeah, I think that's true. I think on big issues, you have to have leadership from the White House, and I think the White House has been engaged. But I think at the end of the day, big issues like this, it'll take the White House and the president being engaged directly to get this done.
You recently wrote an op-ed in The Hill claiming the Medicare physician payment system is broken. You come from the physician community. Tell us why it's broken.
Yeah, I will. First of all, I wanted to associate myself with the comments of my former colleague, Kurt Schrader, and thank you for saying that Congress can actually accomplish some things.
You don't hear that every day,
We
do
miss
you?
him. We miss him on the Energy and Commerce Committee, by the way. So, and so I want to associate myself on his policy discussion too on drugs. I would agree with that. Well, there's a couple of problems. The pie is the same size all the time. We have what's called budget neutrality at CMS, where we can't expand the size of the payment pie. What that means is anytime we try to adjust payment for primary care versus specialists, we're robbing Peter to pay Paul all the time. So we have that is a big problem, and we need to address that. The problem is that's very expensive. The other issue is if you look at the situation with inflationary updates, hospital care, both inpatient and outpatient, get annual updates based on inflationary measures. Providers do not. So if you look at the long-term graph on that, you see that hospitals and others in the healthcare system, based only on inflation, is going like this. Provider reimbursement is flat. So if you consider what our inflation has been the last couple of years, even if we stay with no adjustment, no upward adjustment to the fee schedule, we're losing. We're losing a lot of money. So the problem with that is that practice costs are driving this. So as practice costs go up, and as no inflationary adjustments for the provider reimbursement don't go up, my concern is access. And I represent rural America. You're seeing it more and more difficult to maintain medical practices in rural America, and that's a problem, and underserved urban America. Both have very similar problems for slightly different reasons, but the concern about access and quality is there if we don't fix this. Over the last 20 years or so, just based on the inflation alone, providers out there are losing over 20%, just based on no adjustment for inflation. So I have legislation 2474, which is bipartisan with Dr. Miller-Meeks on the Republican side, Dr. Ruiz and Barra on the Democrat side, all doctors, that would adjust the fee schedule annually based on the Medicare Economic Index, which is an index based on practice costs. And, we put that out there. The issue is paying for it.
Right.
We don't have a CBO score yet, but let me tell you, we've created some conversation.
And do you think you'll get that CBO score? Because obviously you need it.
I've asked my leadership for that, so I'd have to defer to that. On issues like this, I think it takes prioritization by leadership.
Right.
And the reality is they've got a lot of priorities right now, right?
Yes.
And
Speaker
so
Johnson has a lot on his
he
plate.
has a lot on his plate, as does the Democrat leader. Either side could ask the CBO. The issue is how do you score this over time when inflation changes, right? So next year, if the inflation is 0, then there's no update for the fee schedule, right? If it's 10%, there's a 10% update if the MEI goes up by 10%. So I've talked to the CBO director about this a number of months ago. We're hopeful that we can maybe use the average inflation over a period of time and just get an estimate. Getting an actual number would be difficult.
What's and I used to cover CMS and the SGR and the fee schedule, all that, and it's a lot of alphabet soup. But what's the impact of it, especially with an aging population?
Oh, it's huge. I mean, I mentioned before, access.
Yes. But what do you think will happen unless policymakers make some serious fixes?
Well, I think you're already seeing it. Okay. First of all, rural and underserved urban America. Okay. Less and less providers want to practice in those areas.
Can't get an appointment. Can't get a doctor.
Right.
So have to travel a long way.
You can't get appointments. You can't get a doctor. So it's an access issue. For me as a healthcare provider, when I look at public policy, I say does it accomplish a couple of goals? Does it accomplish access to everybody, for everybody, regardless of their zip code? And does it impact the quality of health care that people can get? And we clearly, your previous panels have discussed, we clearly have disparities across our country that need addressed. So as reimbursement doesn't keep up, which it hasn't, you're going to see less access in those areas, particularly rural and underserved urban America. And again, that's just not right. We can't have that. And so we had testimony. It's not just my opinion. We had testimony, and there was an economist a couple of weeks ago that said seniors, about 40% of seniors are having difficulty finding a primary care physician.
40%.
That's what he said. Well, what he said it in a positive way. He said, you know, the system is such that 60% of, America's seniors don't have trouble finding a physician. And so when it came to my time to question him, I said, okay, so what you're saying is 40% of the people, and all you have to do is talk to your grandparents or your parents if they're looking for a new, say their doctor retires, right? This happens all the time. And then they start looking around, they go, okay, who takes Medicare? Can I find a primary care doctor? So that's what happens if the fee schedule doesn't keep up. Now, there's people that argue, say, hey, doctors do pretty well, financially. And that for the most part can and is true. The problem is like every other job, so to speak, if the level of expectation of what your level of training and expertise, the level of expectation on your compensation isn't there, then less people will do it. It doesn't matter whether you're an engineer, a lawyer, or whatever. If you drop the expectation for the reimbursement, so to speak, or the pay, and I think we have to look at that reality. Where are we with that? Well, we can't get doctors in rural and underserved America, and why is that? And they'll tell you, we've got a high educational debt coming out of medical school, then we got to do our residency, we got to defer our payments, and then if you look at the reimbursement, I just can't afford to go to underserved urban America or rural America and practice. And so that's the reality. And that's what we have to address. And there are some that say, well, we understand that, but we still think that we need to control healthcare costs by cutting provider reimbursement. I'm talking about physician provider reimbursement. And that hasn't worked. We started that in the late 80s, right?
Yep.
In the late 80s, we started adjusting the fee schedule downward. And does anyone in this room say that we're controlling healthcare costs in the United States? We're not. Hasn't had an impact. All it's done, in my opinion, is decreased access and ultimately will decrease quality.
What are you watching with CMS's implementation of the drug pricing law?
Well, first of all, I didn't vote for it.
Right.
And for a variety of reasons, some of the reasons that you already heard from your previous panels, right? Concern about access to not only current medications, but future medications. And that's not my opinion. I think Congressman Schrader pointed out that CBO has estimated that innovation will drop, and over time, you'll see less medications developed. And so the big concern for me on it was, what is it going to do to access to quality medications, not only currently, but in the future? Some of the medications mentioned by one of your cardiologists on the panel that are high cost but very effective, if they're on the list, do the companies continue to make the medications if the negotiated price drops below their ROI for that product? The answer is no. They won't do that. And I think you also have to look to Europe. And don't quote me on the exact numbers, but if you look at France and other countries, the availability of medications on the U.S. market versus what you can get if you're in France is about 50%. They can only have access to 55% of the medications that are on the U.S. market. And why is that? Because the government won't pay for it.
Right.
And so that's my main concern going forward. And let me just comment on the penalties. I think the 95% penalty on your gross revenue for medication is going to be proven to be unconstitutional based on the takings clause of the Constitution. I mean, you can't just tell a company, look, if you don't take a price of 0, which was pointed out is the lowest price, then for the Medicare system or Medicaid, then we're going to take 95% of your gross revenue from that product for the rest of the market. Number one, the drug will drop off the market. Number two, if they do that, I firmly believe that's a takings clause. The line in the Constitution about the government taking without due compensation your money.
I want to get back to your legislation, and it doesn't get the headlines, but you mentioned one bipartisan bill. You have a couple of bipartisan bills that are in the mix right now. What's the strategy in this polarizing time as we head into an election? Can you attach some of these, again, you mentioned the one bill passed by voice vote, so basically unanimously in the House. That's rare.
Yeah.
What's the strategy? Attach it to a fiscal bill that's moving next year? Can the measures move that quickly?
Yeah, I think the bigger legislation, adjusting physician reimbursement based on the MEI, the Medicare Economic Index, is something that's going to require some more work.
Right.
I mean, we know it's costly, it's expensive. Ultimately, it needs to be accomplished. So I don't think you'll see action on that. But I'm also working on bipartisan things on prior authorization. Mm-hmm. Last Congress, we almost had it across the finish line. The CBO came out with a score at the last minute, really, and killed it in the Senate after it passed in the House. Let me just comment on the CBO real quickly. Sure. On how they score health care.
Yeah.
I disagree with how they score health care, and I've had this conversation with them. They don't project future savings.
Like prevention.
Correct.
Right, yeah, I've heard this complaint before.
This is and the other thing they did, like on my prior auth bill, is unfortunately, HHS Inspector General came out and said on MA plans that some of the plans were denying claims that traditional Medicare would be paying at a certain percentage. And so when they scored the prior authorization bill that's trying to solve part of that problem, they scored it at what they're currently doing, not what the statute says they should do. So they set the baseline at what is currently occurring. And then when we tried to fix it and make it that people comply with the statute, they said it cost $16 billion to make people actually follow the law. So you see, that's one area where the CBO doesn't score properly, but they don't score future savings on preventive care. And they say the statute doesn't allow them to do that. And I know we're limited on time, but let me give you a big example that I always give people. The medication that cures hepatitis C, mm-hmm. Okay, came out, extremely expensive. There was a debate, hey, should we pay for this? Because, oh my gosh, scoring this a 10-year budget window, which is what Congress does, that's going to be a ton of money. Because this thing's, I can't remember the cost, right, to get an ROI for the company that developed the product. Except for the fact that if you score it in the out years, it prevents chronic liver failure, it prevents liver transplants, it prevents multiple hospitalizations.
Outside the 10-year window.
Outside the 10-year window. And here's the most important part. It makes people healthier. They live a more productive life for them and their families, right?
Yeah.
And how do you score a person who can now have a productive life, and how do you score the value of that? Well, we have to figure that out, because otherwise we can't fix some of these things in healthcare. We can't. We can't pay for new innovative products, whether that's medications, whether that's medical devices, because if we score them on a 10-year budget window, it costs a bunch of money, but we have to have the ability to say, okay, here is the out savings to the system, which I would argue would be probably 10 times what the initial cost would be. Uh-huh. So that's my challenge on healthcare, and I'm working on it.
A lot of challenges ahead.
Yes.
Congressman, thanks for joining us.
No, it's been a pleasure. Thank you.
Hey, appreciate it.
Thank you very much.
Appreciate it. I want to introduce our next guest, is Congresswoman Nanette Barragan of California. She's a member of the House Energy and Commerce Subcommittee on Health and serves as chair of the Congressional Hispanic Caucus. Welcome, Congresswoman. Thanks so much for joining us. Well, let me ask a question I asked the congressman. Do you think that there's any hope of a deal before Congress gets out of town on a supplemental? That's part one. And part two, and I hate two-part questions, but I'm going to do it anyway, is are you hopeful we can avoid a government shutdown? There's been some concern from congressional Democrats about the White House and negotiations on border issues.
How long do we have today?
We've got a few minutes.
Well, you know, the Hispanic caucus and I am not happy about reports coming out of these talks.
Yep.
I am a firm believer that we should be having a vote on foreign aid. So Ukraine, Taiwan, Israel, that should be a vote. There should be a whole different conversation if we're going to start talking about immigration changes combined with border. Let me tell you, we completely understand that there are needs at the southern border, and those are things that Republicans and Democrats should support, including increased capacity, increasing money to make sure that you're stopping fentanyl from coming across the southern border. Those are all in the president's supplemental, which senators, Republican senators, said no to. $1 billion for ICE beds was in that supplemental that said no to. So I don't believe they really want to fix the problem because they're saying no to things that they know would help, but it's a political football, so I don't think there's a real interest there.
So are you optimistic, or do you look at, I mean, listen, I mean, the deadline's right when you guys get back. They're right on you for the government, keeping the government open.
Yeah, I mean, the government open is a different question, and I think that's going to be a greater challenge. I think that it's going to be up to Speaker Johnson whether he's going to use Democrats to help save government again, because that's what's been happening all year long.
As we've been talking this morning, CMS has announced the first 10 drugs for price negotiations. They treat heart failure, diabetes, kidney disease, among others. What's your take on how CMS is implementing this important law?
Well, I think it's kind of early, but you know, there's some things I like that CMS does, and other things that I don't like that CMS does, and that's the great thing is. If you see something not happening right, it's a time to speak up. That's something that I did on the Alzheimer's work. And so, you know, with drug price negotiation, it's going to be a matter of, you know, just kind of following the process and doing the same thing. But my constituents, when they hear about the drug price negotiation, they're frustrated because it doesn't go into effect right away.
Right.
Right, and so every year I do this really big senior fair. I get 1,200 seniors come out. We get a really packed ballroom, and I tell them about what we did, and they feel relief, like, oh great, now I'll be able to afford, you know, my prescriptions. And then they hear, well, it's only 10, and then like, oh wait a second, what? And then they hear, well, it's not going to go into effect yet, and so then, you know, they're very frustrated. So for us, it's a matter of just making sure it's being done quickly, on time, making sure it's, you know, drugs that people are using that's going to benefit, you know, the greatest good. So I think those are the kind of factors we've been looking at. And
how much of a concern as CMS implements it, and you know, legislation gets a lot of headlines, but implementation does not. But as CMS moves forward on implementation over the next several years, how much, we've been talking about access and utilization, how much should that be a factor that's got to be monitored so there isn't rationing of care, or everyone is getting the access to the drugs they need?
Well, that's a huge issue for me and for the Hispanic caucus. Access to care is the biggest concern we hear about, and it's the biggest thing we see. It's that everybody doesn't have equal access. So that is going to be an important thing, and one of the things we talk very frequently with Secretary Becerra. So having somebody at the table, I think, who understands some of those barriers and challenges, whether it's things like even language barriers, not understanding something because it's not in their language. I even get constituents when I have to do town halls ask me, they don't even understand Medicare. What are all the different parts? And they get confused because they get, of course, all these advertisements about enroll in this program and that program. And so I think there's just a lot of continued outreach we have to do to educate folks, but also making sure that when you're having things like clinical trials, right, that they are in the communities where people have access to them. I represent a very working class district. It used to be the 4th poorest district in California. They just redistricted. I don't know what the new number is. But you know, this was a concern that the people in my district realistically just couldn't get to where they had to go. So I think the same is true with implementation, making sure it's being done in a way that's going to be equitable.
You've been a leader on Alzheimer's. Where are we in the search for a cure? There's some promising treatments out there now.
Well, there's progress being made, and people have marketed it as a huge thing. And I think in the everything's relative, right? When you haven't had anything, you have something. It's a big thing. But for families like me and millions across the country, it's not happening fast enough, right? And we feel like we need something, sooner.
Right.
And that is one of the reasons why, when this all first started happening, just to remind you quickly, when FDA approved the drug way back in 2022, and then CMS said then we're going to cover it.
Right.
I was like, what do you mean? Like, this is an equity issue. Only people who can afford it are going to get it.
Right.
And I remember that at the time, we were in E&C and hearing, and one of my Republican colleagues was speaking out against this. And I'm listening, and I said, wait a second. I agree with that person. I want to speak out, too. And there was pushback from, wait, that's not a Democratic talking point. This is not a Democratic issue, a Republican issue. This is about access and equity and, against the advice of, people who say what they prefer you talk about, let me just say. I did anyhow, and that's when I'm always going over to my Republican colleagues to say, how can we work together on this? How can we partner together on this? And I can't help but notice Dr. Larry Bouchon was your prior guest, which I have a really funny story I want to share with you.
Please do.
So you never quite know how or when Democrats and Republicans are going to come together.
Right.
But years ago, my mom was in the ER, and she was ill, and she had to have emergency surgery. And after the surgery, the surgeon comes in to see my mom, and we got into talking, and long story short, he says to me, oh, do you know Larry Bouchon? And I said, oh, well, I serve on a committee with him, but I don't know him that well. And he said, he was my roommate in medical school. And I said, oh, wow, that's pretty awesome. And I said to the surgeon, Dr. Campbell, I said, I'm going to go find him, and I'm going to see how we can work together. And so when I got back to Washington, one day during votes, I'm asking all the Republicans, where's Larry Bouchon? Where's Larry? And I go find him, and I sit next to him. I introduced myself, and I said, hey, and I told him this. I said, oh, Dr. Camel. He goes, oh, yeah, he was my roommate. And I said, he was my mom's surgeon. And I said, we need to find things to work together on. And so it's really just kind of interesting how, things come together sometimes. So we go often, our staffs work together to see if there's common ground on something that we can work together on. And so that's kind of led us to work on something called the Triumphs for Moms Act that we had. But
and that's not common. I mean, it happens, but it's not common on the Energy and Commerce Committee.
Right. And it's a small world. But what are the chances that my mom's surgeons, was roommates with another member of Congress? So that was pretty neat.
Did you get any good stories about the congressman from the roommate, maybe?
No, but I do often.
Could use that.
I do often go to Larry and say, hey, I know the dirt.
Right, exactly.
But it's he's somebody we've been working on too with the Alzheimer's issues.
And speaking of legislation, how things come about, I wanted to ask you about your Medicare Dental Act of 2023. And my dad's on Medicare, and it came up a couple months ago where I was like, yeah, I don't know where dental falls on this. Tell us about the bill and your strategy for getting it done.
Well, I tell you about this town hall we do every year when we get the 1,200 seniors. And one of the things we hear often about is the lack of being able to go to see a dentist and the coverage. Now, when I was a kid, I grew up in a Latino household. I was the youngest of 11 kids. We always had Coca-Cola. And I didn't really understand how bad it was for you. And I had decaying teeth. I never knew why. Of course, later on now I know. And, it's kind of like my parents, I never really ever saw them go to a dentist. And my parents were 25 years apart. So my father was 59 when I was born. You could say I was the last accident, right? And he never had any teeth. He never had teeth for my entire time that I know him. that I knew him. And so for me, hearing from constituents, not having access myself, having a parent who never even had teeth, and then learning about the connection between seeing a dentist and healthcare in general made it one of the reasons why we looked for any opportunity to work with anybody who would work on it. But the idea here is, of course, that people on Medicare should be able to have dental coverage. And it's something that everybody that I talk to in my district agrees and says, why isn't this done? And why isn't this part of coverage? It's healthcare. And so we've just been pushing on this issue with Senator Cardin on the other side. And, you know, many times, unfortunately, people say, well, the cost. It's always about the cost, right?
Right.
And this is where I think healthcare in America is broken, because we spend way more money waiting until things get so bad and then we cover it. But we don't invest in preventive care. And I think that's one of the reasons that healthcare in America is just completely broken. My mom has diabetes, and one day her A1C was really high. So she had to go to see an endocrinologist. And they gave her this little machine to put on her to monitor her sugar all the time.
Okay.
What happens as soon as her A1C fell under 8? They take it away. Oh, Medicare won't pay for this anymore because your A1C is not high enough. Like, this is ridiculous. You're gonna you're only gonna cover something when you are that sick. You're not gonna cover something to help prevent and keep somebody's diabetes under control. And this, again, is my frustration I have with our healthcare system, and why I try to partner up with anybody I can to address these. And a lot of the times, the issues I'm working on are issues that I personally deal with one of my sick parents or a family member, and then that becomes like the signature champion issue. By the way, I'm very excited that we are going to be voting on the Parkinson's bill. My father had Parkinson's, and I grew up watching him with Parkinson's, and most of my memory of him is with Parkinson's and him shaking, and us, you know, laying in the bed together, and me holding his arms because I wanted the shaking to stop as we would, you know, watch baseball. And so to see that there had been a compromise, because I know there was some politics behind what the final bill was going to look like, and it almost didn't get a bipartisan vote. To see that, you know, kind of worked out and coming to the floor, and of course with our colleague Jennifer Wexton, who has been a dear colleague, and kind of watching has been really hard. But it's really our personal experiences that sometimes move us. And I have a sister now with multiple myeloma, and you know, when I heard about Steve Scalise getting, I thought for a moment, like, maybe this is something we can work on together, right? Making sure that we're investing and doing what we can to make sure that there's progress in that field and area as well.
Speaking of working together, we had an audience question from Becca Durr of Novartis. Do Democrats see areas of agreement on technical fixes to the IRA? We were talking about this earlier this morning. Just in this polarizing time, it's really, as you know, technical fixes to big legislation are common. Sometimes that doesn't mean they're easy to do.
Right.
What are your thoughts on that?
I'm open to them, and there frankly are things that we hear about now that my initial reaction is like, oh, that's terrible, like we have to fix that. I have heard about the small molecule problem and its connection to multiple myeloma, and how what's going to happen is there's going to be more investments in infusion as opposed to pills. And as somebody who hates needles and has a really hard time with needles, for me that's devastating. Like, oh my gosh, people are going to have to go in to get an infusion as opposed to a pill. Makes me definitely give thought to what can we do to fix this. And so I think that there are opportunities always to try to fix something. You know, there's good intentions behind bills, and then sometimes the intention is very different than implementation or how it ends up working out, or negative impacts in other ways. And so I think that that's something we all should always be open to, is making sure we try to fix something if it is not, if the implementation is not as intended, or if, you know, the impact is so large that we hadn't thought about it in advance.
I'm going to end on a big question as well. Both parties are not tackling Medicare reforms or Social Security reforms, but both programs are headed for insolvency at some point. Congress is so polarized now, and obviously it's not going to happen anytime soon, but as you kind of were talking about before, the longer Congress waits to fix things, the harder it is, especially from a cost perspective. Do you think that at some point in the next 2 to 4, 6 years that there's going to be, the parties are going to come together and do what they have to do to keep this program strong?
Well, you know, everything comes down to cost and budgets, and that's what your values are. And, you know, I think there's ways that Democrats feel we could raise dollars that Republicans don't agree with.
Right.
And many times it's people paying their fair share, and that could be something on making sure that the wealthiest are paying their fair share of taxes, which they're not. So I think that's always the concern is our values are in finding ways to pay for things that are different than our Republican colleagues. But the idea of cutting Social Security or Medicare, for me, is a non-starter. So what else can we look at? I mean, we're about to vote on the NDAA, and we find billions and billions of dollars to invest in that. And so it's again, a matter of values. And, you know, our older Americans work hard and pay into the system, and we have a duty and a responsibility to take care of them in their older years, and it's not easy, and people are living longer, so it's certainly something, you know, that I think we need to preserve and expand, not cut.
Yep. There are many challenges ahead. I guess we'll take it 1 month at a time with Congress. Please thank the Congresswoman for joining us this morning.
Thank you.
I'll hand it back to Sarah. Okay. Thanks so much.
That brings us to the end of our program today. Thank you to our moderator, Bob Kuzak, and to all of the amazing guests who joined us today. On behalf of the Hill and our sponsor, the Alliance for Aging Research, we would like to thank all of you who joined in person and online. If you missed any portion of today's discussion, or would you like to watch it again, it'll be available on thehill.com in its entirety shortly. Thank you for joining us today. Have a great rest of your day.